There is a specific sensation that millions of men over 60 experience every single day. A dull pressure, sometimes an ache, somewhere deep in the lower pelvic region. Diffuse, hard to locate precisely. And nearly every man who has it says the same thing when I ask about it in my office. I thought it was just how things feel at my age. It is not. That sensation is one of the most reliable early indicators of prostate inflammation, and it is the single most ignored sign I see in clinical practice. Not because it is subtle, because men have been conditioned to dismiss it. In this video, I'm going to show you exactly what that sign is, why it is directly linked to what is happening inside your prostate at the cellular level, and what the peer-reviewed research says about the compound that interrupts the biological process driving it, including the precise dose, the precise form, and the timing that makes it work. Hi, I'm Dr. Greg Sean. I'm a urologist who has spent 25 years working with men over 60 on prostate health, urinary function, and cancer prevention. What I found when I started looking at how inflammation, not enlargement, but inflammation presents in older men changed the way I conduct every intake appointment. Because the sign that matters most is rarely the one men bring up. It is the one they did not think to mention. In this video, we are going to cover three things. First, the difference between prostate enlargement and prostate inflammation, and why treating them as the same condition is a clinical mistake that costs men months of preventable damage. Second, the one sign that 9 out of 10 men over 60 are dismissing right now, what it actually means biologically, and exactly why missing it matters. Third, the specific compound that peer-reviewed research shows directly interrupts the inflammatory pathway, the precise form, the precise dose, and the timing that maximizes its effect. Before we continue, if you have been watching these videos and haven't subscribed, take 2 seconds and do that now. Every week, I cover research that your standard appointment won't. Now, let's get into it. The first thing I need you to understand is this. Prostate enlargement and prostate inflammation are not the same condition. They are related, they often coexist, but they have different mechanisms, different warning signs, and they respond to different interventions. Prostate enlargement, benign prostatic hyperplasia, is structural. The gland grows. It compresses the tube that carries urine out. You get frequency, urgency, weak stream, waking 2 or 3 times a night. These are the symptoms every man over 60 has heard about. They are real, they matter, but they are downstream effects of a physical change in size. Prostate inflammation is something different. Prostatitis, in its various forms, is the third most common urologic diagnosis in men over 50. 2 million men per year are diagnosed with it in the United States alone. And in a significant percentage of those cases, the inflammation has been progressing for months before anyone identified it. The reason for that delay is almost always the same. The most common early sign of prostate inflammation is not a urinary symptom, so men do not connect it to the prostate at all. The sign is this: a persistent dull pressure or ache in the perineal region, the area between the scrotum and the lower abdomen. It may also radiate into the lower back, the inner thighs, or present as a vague heaviness deep in the pelvic floor. It is not sharp, it is not dramatic, it does not stop men in their tracks. That is exactly why they ignore it. In 25 years of clinical practice, I have had more patients describe the sensation as just the way things feel now, or probably from sitting too long, than I can count. They attribute it to posture, to exercise, to age. They do not associate it with the prostate because it does not feel like what they expect a prostate problem to feel like. Here is what is actually happening when that sensation appears. The prostate sits at the base of the pelvis, surrounded by a dense network of nerve fibers. When the gland becomes inflamed, the tissue swells, not in the way BPH causes outward structural growth, but internally, in a way that creates pressure on the surrounding nerve tissue. The perineum has one of the highest concentrations of sensory nerve endings in the male pelvic region. When the inflamed gland presses outward into that space, those nerve endings respond. The result is that dull, diffuse ache that men spend months explaining away. Here's what matters most about the timing. By the time urinary symptoms appear, frequency, urgency, weak stream, the inflammatory process is already well established. The perineal pressure is earlier. It is the body signaling before the structural consequences become visible. Missing it means losing months of intervention window. Now let's talk about what is driving the inflammation itself, because this is where the research becomes actionable. The primary switch for inflammatory activity in the prostate is a protein complex called NF-κB. NF-κB is a master regulator of inflammation throughout the body. But in prostate tissue, its activation triggers a cascade of inflammatory signaling molecules, cytokines, that cause the gland tissue to swell, the nerve endings to become sensitized, and the surrounding pelvic structures to respond. NF-κB does not activate in isolation. It responds to oxidative stress, specifically to the accumulation of reactive oxygen species in the tissue. Aging accelerates oxidative stress, and once NF-κB switches on, the inflammatory cascade it triggers does not self-correct without intervention. This is chronic low-grade inflammation. It does not announce itself with fever or acute pain. It accumulates, slowly, quietly, while men attribute the early signals to getting older and do nothing. The research on how to interrupt this cascade points consistently to one class of compounds, bioflavonoids, specifically quercetin. A bioflavonoid found in specific whole foods has been studied directly in the context of prostate inflammation. A randomized placebo-controlled trial published in the journal Urology showed that men with chronic prostatitis who received quercetin supplementation experienced a statistically significant reduction in symptom scores compared to placebo. The mechanism is direct. Quercetin inhibits NF-κB activation, reducing the cytokine cascade at its source, not managing symptoms downstream, interrupting the process upstream. Quercetin also carries direct antioxidant activity. It reduces the oxidative load that triggers NF-κB in the first place. Two mechanisms, both targeting the same root pathway. The foods with the highest quercetin concentrations are capers, red onions, and apples, specifically the skin. Clinical studies use supplemental doses between 500 and 1,000 milligrams daily, typically split into 2 doses taken with meals. Fat improves bioavailability significantly, so taking quercetin alongside a meal containing olive oil or any dietary fat increases absorption. One important note, the clinical studies used concentrated supplemental forms to achieve the specific doses that showed measurable effect. If you are relying on whole food sources, consistency over time matters more than any single serving. The compound needs to accumulate in tissue to suppress the inflammatory pathway consistently. Week 1 to 2, quercetin begins accumulating in prostate tissue. Inflammatory markers start to shift. No subjective change yet. This is the accumulation phase, the body building its biological foundation. Week 3 to 4, oxidative load in the prostate tissue begins to decrease. Some men report a reduction in the perineal pressure during this window. Not dramatic, but it begins. Week 6 to 8, NF-kappa B suppression becomes measurable in clinical studies at this stage. Symptom improvement is more consistent across the research. Urinary symptoms, where present, also begin to improve as the inflammatory component reduces. Month 3, the compounding effect. Reduced ongoing inflammatory damage means the tissue is no longer being continuously aggravated. Recovery begins to outpace decline. Quercetin from whole food sources has no documented toxicity at normal dietary intake. At supplemental doses of 500 to 1,000 milligrams daily, it has been well tolerated in clinical trials with no significant adverse events in healthy adults. This is not a replacement for any existing medication or treatment protocol you are currently following. If you are under active care for prostatitis or any prostate condition, discuss supplementation with your physician before adding it. This is an addition, not a substitution. If you are experiencing the perineal pressure I described in this video and you have not brought it up with your doctor, bring it up at your next appointment. Do not dismiss it as aging. It is a signal, and the earlier you address it, the less compounding damage occurs in the interim. Subscribe if you have not already. Every week I cover the research that most men never see inside a standard appointment. That is the entire point of this channel. Next week, PSA scores, what the number actually tells you, what it does not, and the 3 dietary factors that the research shows can shift it meaningfully. That is next week.